Important simplified clinical OBG lecture series. So today we'll be dealing on with a very important topic in obstetrics which should never be missed out, that is diabetes in pregnancy. So diabetes is a common medical problem complicating pregnancy that is associated with adverse maternal and perinatal outcomes. Pregnancy may be complicated by diabetes mellitus either due to a pre-existing overt diabetes mellitus or due to glucose intolerance that develops during the pregnancy. So glucose developing during the pregnancy is nothing but the gestational diabetes mellitus. So now let's look at to very important diabetes mellitus complicating pregnancy. So first let's study about the definition of gestational diabetes mellitus, which is very important. So how do you define GDM, gestational diabetes mellitus? So gestational diabetes mellitus is defined as carbohydrate intolerance of variable severity with its onset and first recognition during pregnancy. Very important definition, guys. So GDM is defined as carbohydrate intolerance of variable severity with its onset or first recognition during pregnancy. Note that the definition of GDM does not exclude the possibility of unrecognized glucose intolerance that an antedated pregnancy is. So therefore this GDM does not exclude the possibility of unrecognized glucose intolerance. Definition applies regardless of use of insulin for treatment. Definition applies regardless of persistence of the condition after pregnancy. So the definition of GDM: carbohydrate intolerance of variable severity with its onset or the first recognition during pregnancy. So the incidence of diabetes mellitus in pregnancy is around 3 to 10%, of which GDM accounts for 90% of the cases of diabetes mellitus in pregnancy. So there are certain types of GDM. So what are the types of GDM? So GDM types can be divided into two types. First is a true GDM, true gestational diabetes mellitus, and the second one is pre-gestational diabetes mellitus or an overt DM. So what is overt DM? Pre-gestational diabetes mellitus is otherwise known as overt DM and true DM. So true gestational diabetes mellitus is the onset of glucose intolerance during pregnancy. So GDM can be divided into two types. True gestational diabetes means the onset of glucose intolerance is during pregnancy. So only during the pregnant period they are having just diabetes mellitus. Okay, they are diagnosed with diabetes mellitus only during the pregnancy. So that is known as true gestational diabetes mellitus. Whereas a pre-gestational diabetes mellitus or an overt diabetes mellitus means the DM is recognized for the first time during pregnancy. Which means already even before pregnancy the mother would have been having this diabetes mellitus, but her recognition itself, her diagnosis itself is made only first time during pregnancy. That is pre-gestational DM or overt DM. Now let's look at the high risk factors for GDM. So what are the high risk factors for GDM? High risk factors for GDM, there are certain risk factors associated with the present pregnancy and certain risk factors that are associated with past obstetric history. So what are the high risk factors for GDM in case of present pregnancy? First, you need to see if the mother is an elderly gravida. So elderly gravida mother are generally prone for GDM. Then obesity, whether she is a known case of polycystic ovarian disease, PCOD. whether she is having recurrent urinary tract infection, recurrent vulvovaginal candidiasis, persistent glycosuria, polyhydramnios, fetal macrosomia, family history, that is history of GDM in the first degree relative. So the high risk factors for GDM in present pregnancy are elderly gravida, obesity, known case of polycystic ovarian disease, recurrent UTI, recurrent vulvovaginal candidiasis, persistent glycosuria, polyhydramnios, fetal macrosomia, family history, that is history of GDM in the first degree relative. Next, moving on to the high risk factors for GDM in case of past obstetric history. So in past obstetric history, you have to ask whether she is having history of GDM in any other previous pregnancy, history of intrauterine death IUD, history of stillbirth, history of unexplained neonatal death. So history of unexplained neonatal death, history of macrosomic baby, big baby, macrosomic baby, history of congenital anomalies, history of shoulder dystocia, history of nerve injuries like Erb's palsy, and history of birth trauma, history of early onset preeclampsia, and history of recurrent pregnancy loss. So all that you'll need to know in past obstetric history is history of GDM in any previous pregnancy, history of intrauterine death, history of stillbirth, history of unexplained neonatal deaths, history of macrosomic baby, history of congenital anomalies, history of shoulder dystocia, history of nerve injuries or Erb's palsy, history of birth trauma, history of early onset preeclampsia, history of recurrent pregnancy loss. So history of recurrent pregnancy loss, history of early onset preeclampsia, history of birth trauma, Erb's palsy, shoulder dystocia, congenital anomalies, macrosomic baby, unexplained neonatal death, all just will come under past obstetric history. So moving on to the case presentation. So what all are the salient points that you'll be asking in case of history? So first, consider the following relevant points during history taking in cases of diabetes in pregnancy. So the first history that you'll be asking for is the age of the patient. How age of the patient is important in a GDM case. So overt DM and GDM are more common with advancing maternal age. That is, as I said already, elderly gravida is a high risk factor for GDM. Next, moving on to present pregnancy. So in present pregnancy, if the patient is diagnosed case of GDM, when was she diagnosed? That is, at what period of gestation is very important to be asked. So what is the time duration of her diagnosis, in which at what period of gestation was she diagnosed? Then how was she diagnosed, you should ask. That is, by what method of diagnosis, whether OGTT, that is oral glucose tolerance test, or either by doing a random blood sugar RBS sample, or fasting and postprandial blood sugar. So by which method was she diagnosed, OGTT or RBS or postprandial blood sugar? Then how is she managed following diagnosis? So how was she managed following diagnosis? Is she on diabetic diet or insulin therapy? Is she on diabetic diet or insulin therapy? If she is on insulin therapy, ask the following. So is she on diabetic diet or insulin therapy? And if at all she says yes to insulin therapy, you need to ask the following for insulin therapy. So is she aware of the dosage that she is given? Who gives the insulin injection? Is it self administration or by any other person such as family member or staff nurse? That is to be asked, whether self administered or by family member or a staff nurse. So who gives the insulin injection? Next, moving on to, does she perform self monitoring of blood glucose, SMBG? So is she performing self monitoring blood glucose? That is to be asked. So how is she managed following diagnosis? Is she on diabetic diet or insulin therapy? Suppose she's saying yes to insulin therapy, is she aware of the dosage? Who is giving the insulin? And does she perform self monitoring of blood glucose? Next, are the blood sugars regularly monitored? Are the blood sugars under control at present? And what were the last blood sugar values if known? So, what was the last blood sugar value that she remembers should be asked. Now, say if the patient is a known case of overt diabetes mellitus prior to pregnancy. If she is a known case of overt DM or pre-gestational DM, was she on insulin or oral hypoglycemic drugs before pregnancy should be asked. Whether she was already on insulin or oral hypoglycemic drugs before pregnancy. Were blood sugars under control at the time of conception? So at the time of conception, were all the blood sugars under control? Because there is an increased risk of abortion and fetal anomalies with uncontrolled sugars during conception and organogenesis. So if there is an uncontrolled sugar level during conception and organogenesis, there is a high risk of abortion and fetal anomalies. So that is why we are asking this question, where the blood sugars under control at the time of conception. Next, whether fetal anomaly scan was done and told to be normal. So whether the fetal anomaly scan was done and told to be normal, that is increased risk of congenital anomalies in overt DM. So we need to ask this question. So whether the fetal anomaly scan was done and told to be normal, because increased risk of congenital anomalies in case of an overt DM. History of recurrent urinary tract infection and recurrent vaginal infections. These two should be asked. All history of recurrent UTI and recurrent vaginal infection. History of increased weight gain and symptoms of preeclampsia. Very, very important. All the symptoms of preeclampsia such as proteinuria, blurring of vision, epigastric pain, all the symptoms of preeclampsia must be asked. Now next, moving on to the past obstetric history. So you need to ask for history of GDM in previous pregnancy if present. So any history of GDM in previous pregnancy must be asked. And suppose if it is present, yes, then you need to ask for the period of gestation at diagnosis, whether she was on diet or insulin therapy, any other antepartum complications such as, so any other antepartum complications such as preeclampsia, polyhydramnios, antepartum hemorrhage. Next, moving on to the delivery details. Delivery details are whether should be asked for past obstetric history, whether it was an induced or a spontaneous labor. So why do we ask this question, whether induced or spontaneous labor? Patients with GDM, especially on insulin, are usually induced at 38 completed weeks. So generally during delivery, GDM patients on insulin, they are generally induced labor. So they are having an induced labor at 38 completed weeks. Next, you need to ask for the mode of delivery and then the baby details. Next, moving on to the history of IUD, that is intrauterine death, big baby, birth trauma, difficult delivery, stillbirth, perinatal death, and congenital anomalies. So history of any intrauterine death or big baby or birth trauma, difficult in delivery, stillbirth, perinatal death, and congenital anomalies. All of this, history of intrauterine death, big baby, birth trauma, difficulty in delivery, stillbirth, perinatal death, and congenital anomalies, whether OGTT was repeated after 6 weeks following delivery. So, whether OGTT was repeated after 6 weeks following delivery. So, all these questions must be asked. History of intrauterine death, big baby, birth trauma, difficulty in delivery, stillbirth, perinatal death, and congenital anomalies, whether OGTT was repeated after 6 weeks following delivery, all of this. Next, moving on to the family history. So, under family history, history of diabetes mellitus in the first degree relatives is very, very important. Next, moving on to diet history, whether the patient is taking a diabetic diet or not. So these are the salient points that we have seen is all the salient points in history. Now moving on to the salient points in case of examination in a overt DM or GDM case. Consider the following relevant points during examination. So first, what are we going to look in general examination? So in general examination, height, weight, BMI, pallor, then pedal edema, blood pressure, because always remember preeclampsia is common in patients with GDM. So they are like sisters. So preeclampsia and GDM are generally like both of them are together. Therefore, preeclampsia, BP you need to check because preeclampsia is common in patients with GDM. Next, moving on to the features of PCOD. PCOD features, polycystic ovarian disease, such as what are the features of PCOD? Acne, hirsutism, acanthosis nigrans. All these three are looked for. Acne, hirsutism, acanthosis nigrans. Next, moving on to obstetric examination. So under obstetric examination, you look for the fundal height and symphysis fundal height. So fundal height and symphysis fundal height maybe fundal height is generally more than the period of gestation because of macrosomia or polyhydramnios. So fundal height is more than period of gestation because of macrosomia or polyhydramnios. So if you look at the amount of liquor, polyhydramnios is going to be present, and estimated fetal weight is going to be more, that is macrosomia will be present. So these are the examination importance of an general examination and importance of obstetric examination in case of GDM. So now let's look at how to write a case summary in case of GDM. An example of writing summary in cases of diabetes in pregnancy is given. So example is Mrs. T, dash years of age, 26 years of age, primigravida at 34 weeks of gestation. So Mrs. dash year age of age, whether she is multigravida or primigravida, okay, at what weeks of gestation and what is the period of gestation. A diagnosed case of GDM on insulin, whether she is on insulin or not, since for how many weeks of gestation, since say 28 weeks of gestation, has been admitted for blood sugar profile. So she's been admitted for what? Whether for in case of blood sugar profile, right, blood sugar profile. She has no specific complaints. She is perceiving normal fetal movements. So she has no specific complaints. She is perceiving her normal fetal movements. There is no history of bleeding, PV, leaking PV or labor pains. She has no specific complaints and she is perceiving her normal fetal movements. There is no history of bleeding PV, leaking PV or labor pains. Both of her parents are diabetic. You need to ask the family history. Then her obstetric examination reveals a singleton live fetus In cephalic presentation, a singleton live fetus in cephalic presentation, uterus is going to be relaxed and like a appears average in amount. So the uterus will seem to be relaxed and the liquor is appearing average in amount. Fetal heart rate is how much? Say 144 beats per minute. Regular, heard on the left spino-umbilical line. So how will you write a case diagnosis? So example is 26 years of age, primi gravida at 34 weeks of gestation with GDM on insulin with a singleton live fetus in cephalic presentation, not in labor. So example is 26 years of age, primi gravida at 34 weeks of gestation with GDM on insulin with a singleton live fetus in cephalic presentation, not in labor. So now let's look at the screening for GDM. So it is important to screen, diagnose and treat hyperglycemia in pregnancy to prevent adverse maternal and perinatal outcomes. There is no international consensus regarding the timing of screening, method of screening and diagnostic criteria for GDM. So let's look at a simplified version of screening and diagnosis. So first, whom to screen is the first question. So whom to screen? So there is a universal versus a selective screening. So universal screening for GDM is done for all pregnant women. This is the main question. So universal screening is done for whom? If they ask you in Viva, you need to tell it is done for all the pregnant women. Whereas there is something known as selective screening. So selective screening is done for whom? Selective screening is the screening that is based on risk. Screening based on risk stratification. So risk is going to be assessed at the first antenatal visit. So during the first antenatal visit, the risk will be assessed. So during the first antenatal visit, risk will be assessed. And you need to see the risk stratification. So this is the risk stratification table which you all must know. Risk stratification to screen for GDM in pregnancy. So risk category are of three types: low risk, average risk and high risk. So who are the members belonging to low risk category? All of the following factors should be fulfilled in case of low risk category. First, age less than 25 years. Normal pre-pregnancy body weight. A normal pre-pregnancy body weight. No history of diabetes in first degree relatives. So there is no history of diabetes in first degree relatives. No history of abnormal glucose metabolism and no history of poor obstetric outcome. Next, average group is just the members belonging to various ethnic groups and usually done around 24 to 28 weeks. So high risk is what you need to know very much. So age more than 30 years is a high risk factor. Obesity, family history of type 2 DM in the first degree relative. Previous history of GDM. Is there any previous history of GDM? Past history of bad obstetric outcome. Any past history of bad obstetric outcome and persistent glycosuria. So these are all high risk category. So for high risk, the screening should be done as soon as feasible and repeated at 24 to 28 weeks. So as soon as feasible, they will finish it off and they'll repeat it around 24 to 28 weeks. So now let's look at the disadvantage of selective screening. So 90% of pregnant women have some risk factor that necessitates screening, and there is a chance of missing cases with risk-based or selective screening. Hence, selective screening is not cost effective and time effective. So remember this point. Selective screening is neither cost effective nor time effective. Now let's look at the current guidelines for screening of pregnant women for GDM. So universal screening is the one which is accepted by all pregnant women. So these are the current guidelines for screening of a pregnant woman for GDM. So first guidelines is ADA guidelines, that is American Diabetes Association guidelines. Then ACOG, American College of Obstetricians and Gynecologists guidelines. And IADPSG. IADPSG stands for International Association of Diabetes in Pregnancy Study Groups. So IADPSG guideline stands for International Association of Diabetes in Pregnancy Study Group. So first, American Diabetes Association recommendation is to test women with high risk factors at the first antenatal visit. Women diagnosed in the first trimester are treated as overt diabetes mellitus. Very, very important. So women who are diagnosed with diabetes mellitus in the first trimester, they come under the category of overt diabetes mellitus. And this guidelines is also to test women without any prior diabetes at 24 to 28 weeks. So women without prior diabetes at 24 and 28 weeks can be detected here. Now next is ACOG, American College of Obstetricians and Gynecologists. They test the women with high risk factors at the first antenatal visit. Women diagnosed in the first trimester are treated as again overt diabetes mellitus, and also to test women without prior diabetes at 24 to 28 weeks. Then the most important guidelines, which is the International Association of Diabetes in Pregnancy Study Group, is to screening of all women during the first antenatal visit. If screening is negative, the test should be repeated at 24 to test will be repeated at 24 to 28 weeks. So universal screening is recommended for women belonging to Southeast Asian countries, especially including India, as they belong to an ethnic group that is at a high risk for developing type 2 DM. When to screen? Screening in the first trimester helps to identify cases of overt TM that are diagnosed for the first time during pregnancy. Screening for GDM at around 24 to 28 weeks is recommended because placental hormone mediated insulin resistance increases during the second trimester. So placental hormone mediated insulin resistance is very, very important. So placental hormone mediated insulin resistance increases during the second trimester, and glucose levels rise in women who cannot cope up with this insulin resistance. The glucose intolerance is unrevealed during 24 to 28 weeks. Screening in the third trimester limits the time period during which metabolic intervention should be done. So screening for GDM is done at 24 to 28 weeks of gestation. What is the reason? This is a common favorite Viva question. It is because of placental hormone mediated insulin resistance. Placental hormone mediated insulin resistance that generally increases during the second trimester, and glucose levels rise in women who cannot cope up with this insulin resistance. Now, what are the current guidelines on time of screening for GDM? So it is recommended to screen pregnant women at the first antenatal visit, and if the test is negative, screening should be repeated at around 24 to 28 weeks. Now, how to screen for GDM? Screening may be done by two-step or a one-step procedure. So the current guidelines on time of screening of pregnant women for GDM is International Association for Diabetes and Pregnancy Study Groups, and DIPSI. DIPSI stands for Diabetes in pregnancy study group in India. So according to IADPSG, the recommendation is fasting blood sugar or hemoglobin A1C or random blood sugar. These three, any of these three is done for all women on the first antenatal visit. It's done for all women on the first antenatal visit, and if results are not diagnostic of any overt DM, if results are not diagnostic of overt DM, 75 gram of OGTT is done at 24 to 28 weeks. So suppose say if the results are not diagnostic of overt DM, 75 gram of OGTT is done at around 24 to 28 weeks. Now according to DIPSI, the test is done at the first antenatal visit, and if negative, it is repeated at 24 to 28 weeks and again at 32 to 34 weeks. So DIPSI, we need to repeat twice, around 24 to 28 weeks and again at 32 to 34 weeks. So the current guidelines on the time of screening for GDM is, it is recommended to screen the pregnant women at the first antenatal visit, and if the test is negative, the screening should be repeated at 24 to 28 weeks. This is the current guidelines of screening. How to screen? Screening may be done either by a two-step or a one-step procedure. So first let's look at the two-step procedure for diagnosis of GDM. So two-step procedure for diagnosis of GDM includes screening with 50 gram of oral glucose challenge test. That is screening with 50 gram of oral glucose challenge test, OGCT, followed by diagnostic OGTT. Okay, followed by a diagnostic OGTT for those meeting the threshold value of OGCT. So it's very simple, guys. Oral glucose challenge test is first done, and if at all it is made, it reaches the threshold value, then after, if at all the value reaches the threshold, then again OGTT should be done. That is a diagnostic OGTT, oral glucose tolerant test is done. Now first let's see how this OGCT 50 gram of glucose screening test is done. So first step is the patient preparation. Patient preparation, it is not necessary to be in the fasting state before the test. So it's always not necessary to be in a fasting state before any test, and so that the test is done irrespective of the time of day and the time of the last meal. So very important point to remember is fasting state before the test is not necessary, and the test is done irrespective of the time of the day and time of the meal. So doesn't mean like it's not necessary that the person should have had a meal. So procedure, the patient is asked to take 50 gram of oral glucose load. Venous plasma glucose is measured 1 hour later. So 50 gram of oral glucose load is given to the patient, after which a venous plasma glucose is measured 1 hour later. So after 1 hour, venous plasma glucose is measured after 1 hour. Now what are the cutoff values? So the cutoff values of oral glucose challenge test is around more than or equal to 140 milligram per DL. So OGCT cutoff value is more than or equal to 140 mg per DL is taking as the cutoff value for doing OGTT. So if you need to perform OGTT, then the threshold value is more than or equal to 140 milligram per DL. OGCT cutoff value of more than or equal to 130 milligram per DL increases the sensitivity to 90%, but the false positive rate also increases. So say if the glucose level is between 120 and 140, then what you have to do, you need to repeat the test after a week. So if at all the glucose is between 120 and 140, So this OGCT should be repeated after a week. OGCT value of more than 200 mg per dl, the patient is more likely to be a case of overt diabetes. So OGCT value more than 200 mg per dl is a case of overt diabetes. Now let's move on to the next diagnostic test, OGTT, oral glucose tolerance test. The patients who meet the threshold value in OGCT. So all the patients who meet the threshold value in OGCT are subjected to a 100 gram 3-hour OGTT or 75 gram 2-hour OGTT. Either 100 gram glucose, go for 3-hour OGTT. Either 75 gram glucose, go for 2-hour OGTT. For diagnosis of GDM, so disadvantages of the two-step procedure are 2 visits are required for diagnosis of so 2 visits are required for the diagnosis of GDM, and the patient is subjected to several needle pricks. So that is the disadvantage of two-step procedure. 2 visits are required for the diagnosis of GDM. So now moving on to one-step procedure for diagnosis of GDM. So this is usually commonly done. So the one-step procedure for diagnosis of GDM is a diagnostic 100 gram or 75 gram OGTT should be done without doing a screening test. So that is one-step procedure. So initially the screening test was OGCT. From the OGCT, the threshold value, then we are going to do the OGTT in case of a two-step procedure. Whereas in one-step procedure, we are directly doing the OGTT test, that is 100 gram or 75 gram without doing the screening test. So with simplification of diagnostic test for GDM, the two-step procedure is not commonly used. It's the one-step procedure which is commonly used. So various diagnostic tests for GDM are, let's look at the first diagnostic test, that is 100 gram OGTT diagnostic test. So for 100 gram OGTT diagnostic test, what is going to be the patient preparation? So patient preparation, the test is done following 3 days of carbohydrate unrestricted diet. So the test for 100 gram of OGTT diagnostic test is following 3 days of carbohydrate unrestricted diet. Okay, so the patient can have any diet which is not carbohydrate unrestricted for 3 days, for that is more than 150 gram per day. Okay, so the test is performed in the morning. So the test will be performed in the morning following an overnight fasting of 8 hours. So that in the morning, you'll ask the patient to come in the morning after performing the test, following an overnight, very very important. So after an overnight fasting of 8 hours, in the morning you'll be taking the sample, but not more than 14 hours. So just restrict the overnight fasting to 8 hours. Now moving on to the procedure of OGTT, the fasting blood glucose is going to be estimated. Okay, FBS, fasting blood glucose is going to be estimated, and this is followed by intake of 100 gram glucose load, and blood glucose is estimated at the first, second and third hours. After asking the patient to take 100 gram of glucose load, the blood glucose will be estimated at first, second and third hours following glucose load. Now let's look at the diagnostic criteria for GDM. So what will be the diagnostic criteria for GDM? The criteria for interpretation of the 100 gram diagnostic OGTT are mentioned. So this is the diagnostic criteria, very very famous and important one. So diagnostic criteria: O'Sullivan and Mahan criteria and Carpenter and Coustin criteria of GDM by 100 gram OGTT cutoff values. So let's look at the two criteria separately. There are actually 3 criteria are there: O'Sullivan and Mahan criteria. So usually this is not done nowadays. Next is the NDDG criteria. NDDG criteria stands for National Diabetes Data Group criteria. And then the Carpenter and Coustin criteria. So Carpenter and Coustin criteria, these cutoff values are commonly used for diagnosis of GDM by OGTT. So the most commonly used is Carpenter and Coustin criteria for 100 gram of OGTT test. So first then finish off Carpenter and Coustin criteria. So the blood sample in Carpenter and Coustin criteria will be plasma glucose estimation. So plasma glucose estimation will be there, and method of estimation of glucose is going to be, the method will be glucose oxidase method. So what is the method of estimation of glucose in Carpenter and Coustin criteria? It is the glucose oxidase method. Glucose oxidase method, which is more specific for glucose, and values are 5% less in case of a Somogny-Nelson method. So just remember these two. So the estimation will be plasma glucose estimation, and the method is going to be glucose oxidase method. So what are the blood sugar cutoff values in case of Carpenter and Coustin criteria? Fasting is more than or equal to 95. First hour more than or equal to 180. Second hour more than or equal to 155. Third hour more than or equal to 140. So fasting blood glucose is going to be more than or equal to 95 cutoff. First hour it's more than or equal to 180 cutoff. Second hour it's more than or equal to 155 cutoff. And third hour more than or equal to 140 cutoff. So you can go through this other two criteria, but very important is Carpenter and Coustin criteria. So now let's look at very commonly used nowadays, that is the 75 gram OGTT diagnostic test. So we finished the 100 gram OGTT diagnostic test. So 75 gram OGTT diagnostic test. So we have IAD-PSG, very important guidelines. IAD-PSG, International Association of the Diabetes and Pregnancy Study Group, recommends 75 grams 2-hour OGTT for diagnosis of GDM. So according to IAD-PSG, it is 75 grams of glucose, 2-hour OGTT. Very important, 2-hour OGTT. So if it was 100 gram glucose, it was 3-hour OGTT. Most famous criteria is Carpenter and Coustin criteria. Now moving on to the 75 gram OGTT diagnostic test recommended by IAD-PSG. So IAD-PSG, International Association of the Diabetes and Pregnancy Study Groups for GDM, is based on hyperglycemia. HAPO study, very famous, very important Viva question. So they will ask, IAD-PSG criteria is based on which study? So the answer is HAPO study. What is this HAPO study? H stands for hyperglycemia, A stands for adverse pregnancy outcome. So HAPO study means hyperglycemia and adverse pregnancy outcome study. HAPO means hyperglycemia and adverse pregnancy outcome study. Hyperglycemia and adverse pregnancy outcome study. So the procedure is, fasting blood glucose is estimated, FBS is estimated. This is followed by intake of around 75 grams of glucose load, and the blood glucose is estimated at around first and second hour following glucose load. So what is the procedure? The procedure is, fasting blood glucose is estimated. This is followed by intake. Okay, you are taking intake of 75 grams of glucose load. 75 grams of glucose load, and blood glucose is going to be estimated. So the blood glucose will be estimated at the first and the second hour following glucose load.
Okay, so let's look at the diagnostic criteria of GDM according to IAD-PSG criteria.
So this is the IAD-PSG criteria, 75 gram OGTT diagnostic criteria. So all these three values are very, very important, must be known. So fasting blood sample, the cutoff is around greater than or equal to 92 mg per dl. So fasting is greater than or equal to 90 per mg per dl. First hour, after first hour sample, if the blood sugar profile is more than or equal to 180 mg per dl, or if in second hour, if it is more than or equal to 153 mg per dl. So fasting more than or equal to 92 mg per dl, first hour sample more than or equal to 180 mg per dl, and second hour sample which is more than or equal to 153 mg per dl. This is the cutoff value for 75 gram OGTT diagnostic criteria by IAD-PSG. So the interpretation is GDM is diagnosed if one or more value is abnormal. So even if one or more value is abnormal, okay, then you will interpret as GDM. Now let's look at the American Diabetes Association recommendation. So according to ADA, American Diabetes Association recommends either 75 gram OGTT with IAD-PSG cutoff value or 100 gram OGTT with Carpenter and Couston or NDDG, that is National Diabetes Data Group. Carpenter and Couston is very important. NDDG stands for National Diabetes Data Group cutoff value. So according to American Diabetes Association, either 75 gram OGTT with IAD-PSG cutoff or 100 gram of OGTT with Carpenter and Couston or NDDG. Now, what is the WHO diagnostic criteria for GDM is very, very important. So coming to the WHO diagnostic criteria for GDM, so the WHO in 1999 recommended a 75 gram OGTT with a second hour plasma glucose cutoff value of greater than or equal to 140 mg per dl for diagnosis of GDM. So in 75 OGTT with a second hour plasma glucose, the cutoff is more than or equal to 140 mg per dl. So this is the American Diabetic Association, and along with that NDDG cutoff values and Carpenter and Couston values. So let's look at this. So this table is more than enough to know both 75 gram OGTT and 100 gram OGTT. So first look at the 75 gram OGTT cutoff. Fasting 92, first hour 180, second hour 153. All these three values are important. Now moving on to 100 gram OGTT test. 100 gram OGTT, there are mainly two criteria which you need to know. One is Carpenter and Couston criteria, and NDDG, National Diabetic Data Group. National Diabetic Data Group. So you need to know the Carpenter and Couston value as well as National Diabetic Data Group. So first, under Carpenter and Couston value, 100 gram OGTT, the fasting should be more than or equal to 95. First hour is going to be more than or equal to 180. Second hour is more than or equal to 155. And third hour more than or equal to 140. So according to Carpenter and Couston criteria, 100 gram OGTT, there is 3 hourly test plus fasting sample. Fasting sample is 95, more than or equal to 95 mg per dl. First hour, second hour, third hour are respectively 180, 155 and 140. 180 mg per dl more than or equal to 180 mg per dl for first hour, more than or equal to 155 mg per dl for second hour, and more than or equal to 140 mg per dl in third hour. These are the cutoff for Carpenter and Couston value. Now next is 100 gram OGTT according to National Diabetic Data Group value. So fasting is going to be around 105. It's more 105. First group. So first hour sample more than or equal to 190. First hour sample more than or equal to 190. Second hour sample more than or equal to 165. And third hour sample more than or equal to 145. So here 95, here 105. Addition of 10, okay. Carpenter and Couston value plus roughly 10 will be the value for NDDG. So in Carpenter and Couston value, the value was more than or equal to 95. So plus 10 will be 105. 105 is the cutoff fasting blood glucose cutoff for levels for 100 gram OGTT in NDDG value. So next is first hour. Here 180 plus 10, so 190. Next here 155, so plus 10, 165. Last 140, 145 alone, remember this alone is plus 5. Okay, so very simple. Carpenter and so the first is 75 gram OGTT, very simple, just 3 values to be remembered, 92, 180 and 153. Carpenter and Couston is 95, 180, 155 and 140. Just add 10 for NDDG value, that is 105. Then 180 plus 10, 190, 155 plus 10, 165. So here 140 and last is 145. So this is the WHO, this is the ADA diagnostic criteria. AD, American Diabetic Association diagnostic criteria for GDM. Next, moving on to a very, very important one, that is WHO diagnostic criteria. So the WHO 75 gram OGTT diagnostic criteria for GDM is going to be, so in so blood sugar cutoff value for fasting blood sugar levels more than or equal to 126 mg per dl. So if she is a non-pregnant lady, it is DM. If pregnant lady, also DM. Next, fasting blood glucose level around 100 to 125. 100 to 125 means in a non-pregnant women impaired fasting glucose. In a pregnant lady, it's nothing, no diagnosis. Then postprandial blood glucose level more than 200 is DM in case of pregnancy, and postprandial more than 140 but less than, more than 140 and less than 200 is GDM, gestational diabetes mellitus in pregnancy. So very, very important, just remember these 3 values for pregnancy. If more than or equal to 126 mg per dl, then she in a pregnant lady, then it is diabetes mellitus, fasting blood glucose level. And suppose postprandially it is more than 200 mg per dl, then it is again diabetes mellitus in case of pregnancy postprandial. And if the postprandial blood glucose level is more than 140 but less than 200, it is GDM in a pregnant woman. So studies have shown that the prevalence of GDM in pregnant population is equivalent to the prevalence of impaired glucose tolerance in a non-pregnant population in the age group of 25 to 40 years. Hence, the glucose level that is diagnosed as impaired glucose tolerance. So what is IGT? IGT stands for impaired glucose tolerance. So impaired glucose tolerance in a non-pregnant population in the age group between 25 to 40 years, the level, when will you diagnose it as impaired glucose tolerance is more than 140 but less than 200 mg per dl in a non-pregnant women population. Very, very important. What is IGT? IGT stands for impaired glucose tolerance. Impaired glucose tolerance is nothing but when glucose level is diagnosed as more than 140, more than or equal to 140 mg per dl, but less than or equal to 200 mg per dl in a non-pregnant population is known as IGT, impaired glucose tolerance. So suppose if it is a non-pregnant state, then it is IGT, but if it is during pregnancy, it is GDM. So GDM, if it is more than postprandial more than or equal to 140, less than or equal to 200 in a pregnant lady, is going to be GDM, gestational diabetes mellitus. The significance of impaired fasting glucose in pregnancy is not clearly established. Now, WHO recommends the 75 gram OGTT with IAD-PSG cutoff values for diagnosis of GDM. Now next, moving on to American College of Obstetricians and Gynecologists. American College of Obstetricians and Gynecologists still recommends the two-step approach, 50 grams of glucose GCT followed by 100 grams of OGCT. Or OGCT followed by 100 grams of OGTT, either by Carpenter and Couston or NDDG cutoff. Okay, so what are the disadvantages of all the above mentioned OGT criteria? So overnight fasting is required, that is a disadvantage. So the patient should have another visit to the hospital in fasting state to get this test done. This disadvantage is overcome by DIPSI. So why are we going for DIPSI? Why DIPSI 75 gram? So DIPSI 75 gram OGTT. So the only difference is no need of fasting. Okay, because it is fasting is a disadvantage, we are going for DIPSI 75 OGTT. So what is this DIPSI? DIPSI stands for Diabetes in Pregnancy Study Group in India criteria. So diabetes in Pregnancy Study Group of India. Diabetes in Pregnancy Study Group in India, DIPSI, recommends a non-fasting 75 gram OGTT. That's the very, very important. So the diabetes in pregnancy study group in India. So diabetes in pregnancy study group in India is nothing but recommending a non-fasting. That is the key word here. Non-fasting 75 grams of OGTT. So that is DIPSI. Diabetes in pregnancy study group in India is recommending a non-fasting 75 gram OGTT with a second hour cutoff of greater than or equal to 140 mg per dl for the diagnosis of GDM. So the non-fasting 75 gram OGTT requiring a second hour sample. Okay, second hour cutoff sample of more than or equal to 140 mg per dl for the diagnosis of GDM. For the diagnosis of GDM, it's requiring a second hour sample, okay, of more than or equal to 140 mg per dl. So let's come to the procedure. So the procedure, irrespective of the last meal, that is no need of any fasting state, irrespective of the last meal, 75 gram glucose load is going to be given. So irrespective of the last meal, 75 gram of glucose load, 75 gram of glucose load is given, and second hour blood glucose value is also estimated. So very, very important, no fasting, no need of fasting, and no irrespective of any of the last meal, 75 gram glucose is given and a second hour blood glucose is estimated. Now let's look. DIPSI recommendations on OGTT cutoffs. So based on the second hour venous plasma glucose mg per dl, very, very important. So second hour, so we are giving 75 grams of glucose to drink by the patient. After taking 75 grams of glucose in, we are going to take the second hour venous plasma glucose. So by measuring the second hour venous plasma glucose, is any of this cutoff, this is the interpretation. That is, if it is more than 200 mg per dl, then the interpretation is diabetes mellitus. If it is between 140 to 200 mg per dl, then the cutoff is going to be around GDM. Interpretation is GDM. And if the second hour venous plasma glucose in mg per dl is around 120 to 140, then DGGT. What is DGGT? Decreased, very important, DGGT stands for decreased gestational glucose tolerance. DGGT stands for decreased
gestational glucose tolerance. So DGGT stands for decreased gestational glucose tolerance, which means there is a risk of polyhydramnios. That's the diagnosis. Interpretation. So the interpretation according to a second hour venous plasma glucose, if it is more than 200 mg per dl, then the interpretation is a DM. If it is between 140 and 200 mg per dl, then it is gestational diabetes mellitus. If it is between around 120 to 140 mg per dl, that is 120 to 140 mg per dl, then it is going to be DGGT, that is a decreased gestational glucose tolerance, and there is a risk of polyhydramnios. DIPSI recommends OGTT at around the first antenatal visit, and if at all negative, to be repeated at, if it is negative, then it is to be repeated at around 24 to 28 weeks, and again at 32 to 34 weeks. First is you're going to repeat around 24 to 28 weeks if negative, and again during 32 to 34 weeks if again negative. So testing at the first visit identifies an overt diabetic cases, that is prevalence of DM in India is very high. Second hour sample more than or equal to 200 mg per dl is going to be DM at the first antenatal visit. So prevalence of if at all you're going to test during the first visit identifies overt diabetic cases. A second hour value of more than 200 mg per dl at the first antenatal visit is considered as pre-gestational DM or overt DM. Pre-gestational DM or overt DM. So testing at between 24 to 28 weeks is a time period when actually the glucose intolerance gets manifested, and testing at around 32 to 34 weeks, 32 to 34 weeks identifies cases with a delayed onset of GDM. So let's look at some extra edge. DIPSI does not recommend a fasting state, and testing is done irrespective of meal justification. Pregnancy results in a state of fasting hypoglycemia and a postprandial hyperglycemia, and hence a fasting state is not required. GDM is a state of insulin resistance due to diabetogenic hormones of the pregnancy, which is cortisol, estrogen, progesterone, human placental lactogen. All these are diabetogenic hormones. In normal women with adequate pancreatic reserve, insulin secretion increases to overcome the insulin resistance in pregnancy. Patients with GDM are not able to cope up with the insulin demand to meet the peripheral insulin resistance that occurs during pregnancy. So the patients with GDM are not able to cope up with the insulin demand to meet the peripheral insulin resistance that occurs during pregnancy. Glucose challenge, irrespective of last meals, results in adequate and brisk insulin response in normal women to maintain the euglycemic state, while women with GDM have impaired insulin secretion, resulting in an increase in glucose levels. So DIPSI recommends the 75 gram OGTT to be done in the first antenatal visit. Why? The justification is it helps to identify cases of overt DM, and fetal pancreas starts developing by around 9 weeks of gestation. So if hyperglycemia is present at this time, pancreatic memory of this hyperglycemic insult may result in the development of DM in the offspring later in life. So what are the advantages of DIPSI criteria? So it is a single step procedure for screening and diagnosis of GDM, and the second visit is actually not necessary for the diagnosis. It is patient friendly. Tests can be done during routine antenatal visit as well as a fasting state is not required. The economic loading dose is just 75 grams in DIPSI in all the 3 trimesters, and it is much more cost effective than a single 100 gram OGTT, which requires 4 values for a single test. Now, extra edges IAD PSG criteria is the only outcome based criteria. IAD PSG 75 gram 2 hour OGTT cutoff values for GDM are based on the blood glucose values that resulted in the adverse pregnancy outcomes, while 100 gram OGTT diagnostic criteria cutoff values are based on blood glucose values associated with the development of subsequent type 2 diabetes mellitus. So, DIPSI cutoff value has not been put to test to find out the correlation and adverse perinatal outcome. So, screening in Indian conditions, the following facts are applicable to Indian population. Indians have a high prevalence of diabetes, and hence universal screening at the first antenatal visit is actually recommended. So this is the diagnostic criteria for GDM as per different organizations. If you see, this one table is more than enough to summarize everything that we have studied. First, American Diabetes Association, IAD PSG, International Association of the Diabetes and Pregnancy Study Group, and ACOG, American College of Obstetricians and Gynecologists, WHO, and DIPSI. So DIPSI is very simple, 75 gram, and second hour venous sample alone is taken, and the value cutoff is more than or equal to 140. WHO, according to 75 gram IAD PST, the values are more than or equal to 92, more than or equal to 180, and more than or equal to 92, 180, and 153. And according to WHO, it is just greater than or equal to 140 in the second hour venous sample. ACOG 100 gram glucose load by Carpenter and Couston, it's 95, 180, 150, and 140. NDDG, the cutoff values are 105, all plus 10, 190, 165, and 145. DIPSI criteria is recommended as it will serve as a one-step diagnostic test that is economical and easy to perform. The IAD PSG recommendation of screening all the pregnant women during the first antenatal visit with a 75 grams or 75 grams 2 hour OGTT is currently followed in many other countries. So other methods of screening for GDM are going to be, first is fasting blood sugar. Fasting blood sugar is not useful as pregnancy is a state of fasting hypoglycemia and postprandial hyperglycemia. Next, moving on to random blood sugar. Random blood sugar is not recommended for diagnosis of diabetes mellitus. Next, coming to glycosylated hemoglobin, reflects the glycemic control over the past 2 months. Half-life of RBC is 60 days and is not affected by recent or transient increase in blood glucose levels. For non-diabetic patients, the normal range of HbA1c is going to be 4 to 5.6%. Incidence of congenital anomalies increases with higher values of HbA1c. HbA1c more than 10%, so the incidence of congenital anomalies is 14%. So fasting blood sugar, random blood sugar, and glycosylated hemoglobin. Fructosamine assay, glucose polymer challenge test. Advantage, lesser gastrointestinal symptoms. So intravenous glucose tolerance test.
intolerance to oral glucose such as vomiting, altered gastrointestinal absorption, urine glucose. Urine glucose it is not specific as renal glycosuria can be present during pregnancy in 50 to 50% of cases. Renal threshold decreases during pregnancy due to the following: increased glomerular filtration rate, impaired tubular reabsorption of glucose, and capillary blood glucose estimation using glucometer. It is not recommended for diagnosis of GDM due to lack of standard threshold values. However, glucometer is widely being used to follow up patients with GDM following diagnosis by standard method. So the diagnostic criteria for an overt DM. So what is the diagnostic criteria for an overt DM? So the fasting blood sugar level more than or equal to 126 mg per dl, the random blood sugar level over than equal to 200 mg per dl, and HbA1c more than or equal to 6.5 mg per dl. Just diagnostic criteria for overt DM is must know. So what is the criteria for overt diabetes mellitus? Fasting blood sugar more than or equal to 126 mg per dl, more than or equal to 126 mg per dl, random blood sugar more than or equal to 200 mg per dl, and HbA1c levels more than or equal to 6.5 mg per dl. Fasting blood sugar more than or equal to 126 mg per dl, random blood sugar more than or equal to 200 mg per dl, and HbA1c levels more than or equal to 6.5 mg per dl. So next, moving on to the complications of GDM in pregnancy. So complications of GDM in pregnancy are effects of pregnancy on diabetes mellitus. So the pregnancy worsens the pre-gestational or as well as the overt DM cases. Those on diabetic diet may actually require insulin therapy. So those who are actually on diabetic diet require insulin therapy as well. Those on oral hypoglycemic drugs have to be changed to insulin. Okay, those who are on oral hypoglycemic drugs have to be changed into insulin. So very important. So effects of pregnancy on DM, and who all the patients who are actually on diabetic diet must require insulin therapy. All on oral hypoglycemic drugs should be changed to insulin. Those on insulin may require higher doses of insulin. Pregnancy worsens diabetic vasculopathy such as nephropathy, retinopathy, microangiopathy, and there is an increased risk of diabetic ketoacidosis. Now let's look at a Viva question. Why does insulin requirement increase with advancing pregnancy? This is the Viva question. Why does insulin actually requirement increases with advancing pregnancy? So the insulin requirement increases with advancing pregnancy because increase in diabetogenic hormones of the pregnancy. See, during the pregnancy state, the diabetogenic organs like cortisol, progesterone, estrogen, human lactogenic hormone, all of these are diabetogenic drugs. So because of this, the advancing pregnancy, as the pregnancy advances, the insulin requirement also increases. So the diabetogenic hormones, very important Viva question. What are the diabetogenic hormones of pregnancy? They are human placental lactogen, very important. HPL, human placental lactogen, increased estrogen, and increased progesterone, increased cortisol, and placental insulinase. Human placental lactogen, increased estrogen, increased progesterone, increased cortisol, and placental insulinase. So HPL, human placental lactogen, estrogen, progesterone, cortisol, placental insulinase, all will be increased during pregnancy. Now what is the effect of diabetes mellitus on pregnancy? So the effect of diabetes mellitus on pregnancy is, first coming to the maternal complications. So maternal complications are poor glycemic control. Poor glycemic control is the most important cause for all the maternal complications, like for most of the maternal complications. So pre-gestational diabetes is associated with a higher rate of maternal complications than GDM. Very important. A pre-gestational diabetes okay, or overt DM, the complications are more as compared to GDM. So what are the maternal complications due to DM? So the maternal complications due to diabetes mellitus are, you can categorize it as during the antenatal period, the intrapartum period, and postpartum period. So during the antenatal period, first most important complication is infections. Infections such as recurrent urinary tract infection, pyelonephritis, vulvovaginal candidiasis, all these infections like recurrent urinary tract infection, pyelonephritis, and vulvovaginal candidiasis. Next, coming to preeclampsia, then polyhydramnios. So the most common maternal complication is polyhydramnios, and then preterm labor. So what are the antenatal maternal complications due to DM? Infections can be either UTIs or pyelonephritis or vulvovaginal candidiasis or preeclampsia. After preeclampsia, polyhydramnios, and then preterm labor. So infections, preeclampsia, polyhydramnios, and preterm labor. Infections, preeclampsia, polyhydramnios, and preterm labor. Infections, preeclampsia, polyhydramnios, preterm labor. Next, moving on to the intrapartum maternal complications of DM. So the intrapartum maternal complications of DM are, first is prolonged labor. So the labor duration will be prolonged. Then increase in instrumental delivery and lower segment C-section probability. So instrumental delivery and LSCS. So that will be the most, that's one of the complication mostly. And perineal trauma is a intrapartum complication because it is usually DM is associated with macrosomia, because of which perineal trauma can be there, and postpartum hemorrhage, PPH. So postpartum hemorrhage. So intrapartum complications are mainly due to macrosomia and shoulder dystocia. These are the two important fetal complications because of macrosomia and shoulder dystocia. Because of macrosomia and shoulder dystocia, all these intrapartum complications arises, such as the prolonged labor, instrumental delivery and LSCS, perineal trauma, and postpartum hemorrhage. Next, the last is the postpartum complications in case of DM. So the postpartum complications, again, infections and puerperal sepsis. So what are the complications? Antenatal infections, preeclampsia, polyhydramnios, and preterm labor. Just remember infections, IP3, and 3 P's, that is for preeclampsia, polyhydramnios, preterm labor. And intrapartum complications, just remember the two things. It is due to macrosomia and shoulder dystocia, therefore prolonged labor, perineal trauma, postpartum hemorrhage, instrumental delivery. Then postpartum complications are only infections and puerperal sepsis. So next, moving on to the fetal and neonatal complications. Maternal hyperglycemia is the most important cause for fetal and neonatal complications. So moving on to the fetal and neonatal complications due to DM. So first, let's look at the fetal complications. Let's look at the fetal complications. Second, we'll look at the neonatal complications.